Hi, I am Dr. Selvaraj, Professor of Surgery at Malacca Manipal Medical College, Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. So because of the popular demand by the viewers of this channel, I am uploading videos on trauma also. In this episode, I am going to talk about advanced trauma life support, known by the acronym ATLS. So this advanced trauma life support, or the life support in trauma, is known as ATLS in US, EMST, that is Emergency Management of Severe Trauma in Australia, Primary Trauma Care in UK. So now today all are agreed this ATLS. So internationally in all countries nowadays we are following the ATLS protocol. So most countries are now having an epidemic of trauma because of increased number of vehicles. In India, it is one of the major killers. So almost 200,000 deaths per year. In the state of Tamil Nadu alone, there is 25,000 deaths per year. So what are the objective of this ATLS? Actually, this ATLS course is conducted by the American College of Surgeons. It is actually a 2-day course, consists of didactic lectures and hands-on skill stations. So at the end of the second day, you have to sit for an exam, and if you are successfully completing it, they will give you a certificate that is valid for 2 years. So what are the objectives? It is to rapidly and accurately assess the trauma patients, and it also give you an idea of early recognition and timely intervention of life-threatening condition, to resuscitate and stabilize the trauma patients, to understand the priorities in trauma management, that is called the triage. Ultimately, the main aim is to organize quality trauma care in your hospital. So this trauma management consists of 6 stages or 6 phases. Number 1 is the access phase, that is you are accessing the patient at the accident scenario itself, the scene itself. And then the pre-hospital and triage phase. Then comes the early hospital or resuscitation phase. Then operative phase if it is needed. Then the intensive care phase, and then the rehabilitative phase. So one Dr. Arnold D.Trunkey has described TRIMODAL death in case of trauma. This is known as the death can occur within seconds to minutes in case of brainstem injury or aortic rupture. This we cannot do anything because the patient will die instantaneous death at the scene of accident itself. They won't even come to the hospital. Then the number 2 is within minutes to hours because of some internal bleeding, like because of subdural hematoma or rupture of the liver and spleen, they will go for hypovolemic shock. So these patients has to be transferred to the hospital immediately. And these patients we can save. And another mode of death is within days to weeks after admitted to the hospital. This is mainly because of the sepsis and the multi-organ dysfunction syndrome. This is also preventable. So in trauma case, you have to concentrate mainly on those patients who are going to die within minutes to hours because of some internal bleeding. These patients should be transferred to the hospital within the first golden 1 hour. So ATLS consists of emergency life saving should precede examination of trauma patients. Once the immediate survival is achieved, then only you have to do the definitive assessment, and then only you have to begin the treatment. Priority in the management must always be salvage of life, limb, function, and then only the cosmesis. So the pre-hospital trauma life support consists of the scene size up. That means you have to judge whether the accident scene is safe to enter or not. Before entering the accident scene, the rescuer should wear personal protection devices, and then they have to extricate the patient, that is removing the patient to a safe place, that is called extrication. Then they have to do the primary survey, and immediately if something is wrong in the ABCD, then immediately you have to do the resuscitation, or you have to give what is called the basic life support. Then if there is, you have to put the patient in what is called long spinal board. This is a big board. You have to put them in the long spinal board to transfer or to shift the patient to ambulance. So if there are any fracture in the extremities, you have to put splintage. If there is any hemorrhage, external hemorrhage, you have to control it by a direct pressure or elevation of the limb, and you should not apply any tourniquet. The aim is, the pre-hospital trauma life support aim is, you have to stabilize the patient within the platinum 10 minutes. Suppose if the airway is not patent and if the patient is not breathing, you have to intervene within 8 hours, because the 8 minutes, because the brain cannot sustain, it cannot live more than 8 hours without oxygen supply. So even if you are going to rescue the patient, revive the patient after these 10 minutes, because these patients will be brain dead, and it is useless only. So those patients who are having internal bleeding, you have to load them and you have to transport them to the appropriate hospital facility within the first hour, that is called the golden 1 hour. So the field triage, it depends on, this is the sorting of the patients by the severity of the injury and the need for the transport. So red means these patients are critically injured and they need immediate transfer to the hospital. Yellow means these patients are less critically injured. You can little bit delay the transfer to the hospital without endangering their life. Green means there is no life or limb threatening injury. Patient is ambulatory. They may not need any IP treatment. Black means that is dead patient. So if you are having a mass casualty, then usually they will put this color coding as a tag to their wrist area. So this is what is known as long spinal board. After any severe trauma, you have to put the patient over this board, because then you have to support the patient's cervical spine with 2 sandbags, so that the cervical spine injury won't get aggravated. So then you have to put them in this long spinal board, and then only you have to transfer them to the hospital or to the ambulance first. So what is the overview? First thing is, you in ATLS you must do primary survey first, that consists your ABCD. Then if something is wrong in this ABCD, immediately you have to do resuscitation. If something is wrong in the airway, that is in the A, that is airway, immediately you have to correct that airway. Then only you have to look for the breathing. Then only you have to go for the circulation. Then after stabilizing the patient, after doing the resuscitation and stabilizing the patient, then only you have to do the secondary survey. Then even after secondary survey, every now and then you have to watch for the ABCD, and if something is wrong, again you have to resort to the resuscitation. Then when once the patient's vitals are stabilized, then only you have to proceed for definitive care. So coming to the primary survey, what is primary survey? It consists of your ABCD. So A is airway and cervical spine control. B is breathing and ventilation. C is circulation and hemorrhage control. D is disability. Mainly you will be assessing the neurological status of the patient. E is exposure and the environment. You have to completely undress the patient. So the primary survey, coming to the airway and cervical spine control, okay, if the airway is not patent, then immediately you have to do either chin lift or jaw thrust. If the patient is having any suspected cervical spine injury, don't do the chin lift maneuver. You have to resort only to the jaw thrust. Then you have to look into the throat for evidence of any foreign body, blood or vomitus, and you have to remove all these things from the throat. Then you have to try to put a oropharyngeal or nasopharyngeal airway first. If the patients are GCS is very low, then straight away you can intubate them with endotracheal tube. If the oropharyngeal, nasopharyngeal airway and endotracheal tube is not possible, then you have to resort to the surgical airway, that is called CRICOTHYROIDOTOMY. During all these maneuver, you have to keep the neck immobilized. You should not give undue movement to the neck. That will aggravate the cervical spine injury. So you have to be very careful. So this is the chin lift maneuver. You have to lift the chin. But if the patient is having any cervical spine, suspected cervical spine injury, you have to resort to this. This is the jaw thrust maneuver. And another very important thing is the endotracheal intubation. This is the single skill all the clinicians should acquire. This will you can, by mastering this single skill, you can save a lot of patients. So you have to use a laryngoscope. Either for adult patient, you can use a curved laryngoscope blade, and you can put the tip of the laryngoscope into the vallecula, lift it, and then you can visualizing the larynx. You have to put the appropriate ET tube into the trachea. Here in a pediatric patient, you can use a straight blade, straight laryngoscope. Here you have to include the epiglottis also. You have to lift the area. You have to visualize the larynx properly, and then only you have to insert the endotracheal tube. And if both the oropharyngeal, nasopharyngeal airway and the endotracheal tube is not possible, then you have to resort to the surgical airway, that is known as cricothyroidotomy. This can be done at the scene of accident itself. So you have to make a small nick over the thyrohyoid area, that is in between the thyroid cartilage and cricoid cartilage. You have to make a small nick, and you can just put a small percutaneous tracheostomy tube. Or you can even, if you are not very confident, you can even put a wide bore needle through this membrane. This is only a temporary procedure. Once the patient has reached the hospital, you have to do a proper airway control by doing a tracheostomy. So coming to the second thing, that is the breathing and ventilation. Just because the airway patency is there, that doesn't assure the patient is having adequate ventilation. So you have to look for whether the patient is really breathing or not. You have to look, feel and listen for breathing. You have to auscultate for the breath sounds. You have to ensure adequate oxygen. Start either ambu bag or put a endotracheal tube. The FiO2 should be always more than 0.85. So even then, if the patient is not breathing, then you have to suspect either one of these three things, either a tension pneumothorax or an open chest injury or a flail chest. So if it is a tension pneumothorax, immediately you have to put a wide bore needle in the second intercostal space, and then you have to put a intercostal tube thoracostomy also. If it is an open chest injury, you have to seal that area, otherwise it will produce a open pneumothorax. If it is a flail chest, you have to start intermittent positive pressure ventilation. So this is the ambu bag. If you are connecting it to 100% oxygen, and if you are using an oxygen reservoir, then the patient will getting oxygen around 90 to 100%. If you are not using this reservoir, oxygen reservoir, the room air, which contains only 21% of oxygen, will mix with this 100% oxygen. So ultimately the patient will get only around 40% of the oxygen. So always it is better to use a oxygen reservoir. So coming to the circulation and hemorrhage, post-traumatic hypotension is always, it is hypovolemia unless proved otherwise. So if the patient is conscious and is talking, that means he is having enough blood flow to the brain. If the capillary refill is more than 2 seconds, okay, then also the circulation is okay. If the patient is having pale, cold and clammy skin, that means the patient has lost a blood volume of more than 30%. So circulation, and then it may be the pulse may be rapid and thready. That also indicates the patient is having hypovolemia. If there is no pulse, immediately you have to start the CPR. If there is an external exsanguinating hemorrhage, you can control it with the military anti-shock trouser or pneumatic anti-shock government, but you should never use tourniquet, because these are the, here in this picture you are seeing, this is the military anti-shock trouser or pneumatic anti-shock government. You have to apply it to the lower limbs as well as to the abdomen. You are seeing the ambulance personnel is applying this mask to the patient. So disability, coming to the disability, where you have to assess the neurological status, you can do what is called AVPU. A means the patient is very alert. V means he is responding only to vocal stimuli. P means he is responding to painful stimuli. U is the patient is unresponsive. The GCS, it has to be done only in the secondary survey, because in the primary survey you have to do only AVPU because it is very quick. GCS will take some time. It should be done only in secondary survey. So what are the common life-threatening pathology? If it is airway, it is mainly because of the obstruction of the airway. You have to open the airway by doing the chin lift or jaw thrust maneuver. Breathing, it is mainly because of tension pneumothorax or hemothorax or hemopneumothorax, open pneumothorax or flail chest. If it is circulation, mainly the life-threatening conditions are hypovolemic shock or massive hemorrhage or spinal shock. So you have to start immediately, you have to start 2 large bore IV lines, peripheral IV lines you have to start, and you have to infuse at least 2 to 3 liters of crystalloids, either normal saline or Ringer's lactate. Then you can transfuse type specific whole blood if it is available. If the whole blood is not available immediately, you can transfuse O negative packed RBCs to any patients, any blood group you can transfuse with O negative packed RBCs. The tissue, by transfusing this blood, the tissue aerobic metabolism is assured by perfusion with well oxygenated RBCs. Never treat this hypovolemic shock with vasopressors, steroids or soda bicarb. Then you can put the continuous bladder drainage. You can catheterize the bladder, you can put a nasogastric tube into the stomach, and you can aspirate it if there are no contraindications, because in urethral injury you should not put the bladder catheterization. In cribriform plate fracture, you should not put NG tube. Then you have to carefully do the ECG monitoring, and if there is any arrhythmia, you have to correct it immediately. Then you have to follow the data flow sheet of all the vital parameters to assess the effectiveness of your resuscitation. Then after doing the resuscitation, you have to re-evaluate this airway, breathing and circulation every now and then. Then if there is something wrong in this, again you have to resort to the CPR. So what are the adjuncts to the primary survey? You have to record the vital signs. You have to do the ECG monitoring. You must also do ABG, pulse oximetry, end-tidal carbon dioxide or capnometry. Of course, you have to catheterize the bladder and you have to put the NG tube into the stomach. You have to measure the urinary output. If urinary output is adequate, that means the patient is having enough perfusion to the kidneys. And all trauma patients, you have to give supplemental oxygen. And you must do chest X-ray, cervical spine X-ray and the pelvis X-ray. And apart from that, you should also do direct peritoneal diagnostic peritoneal lavage and the ultrasound, that is called FAST, that is focused abdominal sonography in trauma. So nowadays we are not doing diagnostic peritoneal lavage, in which we used to put a catheter into the peritoneal cavity, infuse a lot of Ringer's lactate or sodium chloride into the peritoneal cavity, around 2 to 3 liters. Then you have to siphon it out and found out whether it contains frank blood or more than 1 lakh RBCs or any fecal matter, all those things. If present, that means it is a positive diagnostic peritoneal lavage and the patient needs immediate laparotomy. But nowadays this diagnostic peritoneal lavage is replaced by the FAST, that is focused abdominal sonography for trauma, in which they will be concentrating only on 4 areas of the abdomen, namely the number 1 is the right hypochondrium to rule out any liver injury. the left hypochondrium to rule out any splenic injury, and the epigastrium to rule out any pericardial tamponade, and the hypogastrium to rule out any pelvic collection or any free fluid in the peritoneal cavity. So then only after stabilizing the patient, you have to go for the secondary survey. Secondary survey does not begin until the primary survey is completed, resuscitative efforts are well established, and patient is demonstrating normal vital signs. Then only you have to do the secondary survey. So secondary survey is nothing but your head to toe thorough examination. That includes you have to look for the head and skull for any trauma. Then you have to look for the faciomaxillary injuries. You have to look for the chest. You have to look for the chest and abdomen, that is the front side, and you have to look the back also, the spine. When you want to see the back, you have to do what is called log rolling the patient. You should not twist his spinal cord. That is the idea. You need at least 2 to 3 person to log roll the patients. So then you have to look for the perineum and rectum, and in female patients even the vagina. If extremities, you have to look for evidence of any fractures. Now you have to do the complete neurological examination. You must do the Glasgow Coma Scale, GCS. Then you have to do appropriate x-rays, lab tests, and special studies. Then you have to do a digital rectal examination also. So this is the Glasgow Coma Scale. So it consists of 3 things: eye opening, motor response, and verbal response. The eye opening consists of totally 4. If the eye opening is spontaneous, the score is 4. If he is opening only to the speech, it is 3. If he is opening for the pain stimulus, the score is 2. If he is not opening for any stimuli, then it is 1. Coming to the motor response, if he obey commands, the score is 6. If he localize pain, the score is 5. If he withdraws to pain, the score is 4. If he is having abnormal flexion or decorticate posturing, the score is 3. If he is doing abnormal extension or decerebrate posturing, the score is 2. If he is not doing anything, if he is flaccid, then the score is 1. The verbal response, if the patient is oriented, the score is 5. If he is confused, the score is 4. If he is uttering inappropriate words, the score is 3. If he is uttering incomprehensible sound, the score is 2. If he is not uttering anything, then the score is 1. So a dead patient will be having 3. The score, the minimum score is 3. The maximum is 15. So then only, unlike the normal patient where you will be eliciting the history first, in a trauma patient you have to ask the history only at the end. So the mnemonic for the history in trauma patient is called AMPLE. A means allergies, M is medications currently taken, P is past illness, L is last meal, and E is events and environment. So coming to the mechanism of the injury, it may be either blunt trauma or it may be a penetrating trauma. Blunt trauma may be because of front impact that will cause myocardial contusion, pneumothorax, flail chest, or cervical spine injury. If it is a side impact, the spleen and liver may get injured, or there may be pelvic fracture, or the patient will get flail chest, opposite cervical spine sprain. If it is rear impact, the patient may go for whiplash injury of the cervical spine. Sometimes, especially if it is a two-wheeler, the patient may be ejected from the vehicle and he will sustain multiple injuries. The penetrating trauma is because of sharp objects like knife or any sharp object, or it may be a missile injury. So here you are seeing the 2 pictures. Here the patient is traveling in a car, he is wearing a seat belt, but even then he can sustain an injury by striking against the windscreen, head injury, over the steering wheel, that is chest injury. Because of the seat belt, it will increase the intra-abdominal pressure, the diaphragm may rupture. If he is not wearing seat belt, okay, he can get a fracture of the femur, he can get fracture of the tibia also, or he can get steering wheel injury to the thorax and facial injuries also. If it is a side impact, he can get a fracture of the humerus, fracture of the pelvis, and fracture of the flail chest, that is multiple rib fractures. Or if it is a pedestrian injury, the patient may be knocked by the bumper of the car. Okay, there will be a fracture in the lower limb, that is the tibia and fibula. Then he may fell over the bonnet, he sustained injury to the thorax. Then he may fell down over the road, he may sustain a head injury and a fracture of the upper limb bones. So these patients will go for what is called polytrauma. So you have to do re-evaluation every now and then. You have to have a high index of suspicion for all the suspected injuries. So frequently you have to re-evaluate the patient, and you have to continuously monitoring all trauma patients. So then only after stabilizing the patient, then only you have to go for the definitive care. That comprises of a comprehensive treatment of all the injuries, fracture stabilization, necessary operative intervention, appropriate intensive care and stabilization. Suppose your hospital or institution is not having facility to treat a major trauma case, then you have to stabilize these patients, and then you have to transfer this patient to a appropriate hospital care. So coming to the triage in the hospital, now this is what is known as the sorting of the patients based on the severity of the injury and the availability of the resources in the hospital. Suppose if the number of the patients and severity of the injuries do not exceed the facility, that means there are only 5 patients and you are having 10 medical officers, then you can treat the most critically injured patient first. Suppose if the same exceeds the facility, that means the number of patients are more, say 100 patients, and you are having only 10 medical officers. This is what is called mass casualty. Then you have to treat as many as salvageable patients as possible. You should not treat the critically injured first in this scenario. You have to treat as many as salvageable patients as possible. So I told you this trauma course that contains hands-on skill station also. So in each station they will teach you one skill. So airway management, okay, they will teach you how to intubate, and they will discuss many scenarios, case scenarios also. Then in the vascular access and fluid resuscitation station, they will teach you how to start the peripheral line and how to start the central line also. Then ECG monitoring and CPR, they will also teach you how to defibrillate the patient. And the special patients, the pediatric and pregnant trauma patients, how to treat them, they will teach you in a separate station. And how to transport these critically ill trauma patients to the hospital, that also they will teach you in a skill station. And in another skill station, they will teach you how to deal with mass casualties or disaster management. So one of these, this is especially in pediatric patient, you will be doing what is called intraosseous needle. Suppose if the patient is severely dehydrated, all the peripheral veins will be collapsed, you may not be able to start a peripheral IV line. In this scenario, you can do what is called intraosseous needle. You can directly puncture the tibia and you can infuse the fluid into the marrow cavity. And this is usually we do it in pediatric patients. And this is the disaster management. In the first picture, you are seeing the Twin Tower casualty in year 2001, and here you are seeing the Pearl Harbor casualty, and here you are seeing a tsunami. So in all these scenes, you will have number of patients where you cannot cope up with all these patients. Here you have to treat as many as salvageable patients as possible. You have to do what is called, to prepare for this scenario, disaster management or mass casualty, you have to do what is called a mock drill. You have to you have to train your team for this disaster management. That is what is called mock drill. So the roles of the trauma patients should be pre-assigned. So one person will be in charge of the airway, one doctor, probably it is an anesthetist. Then another doctor will be in charge of the IV line. This nurse will be helping this doctor, and another person will be in charge of the urinary catheterization. And there will be a team leader. He has to decide what to do to this patient, and he has to decide about the referral also. So this is the example of what are the different roles. Doctor number one, doctor he is concerned with the overall charge of the case. He is the team leader. He is in charge of the airway plus cervical spine control. He is in charge of the ventilation. He dictates orders of priorities. He decides regarding the referral. So doctor 2, second doctor, is in charge of the IV line. He is in charge of the blood samples and urinary catheter also. The nurse number 1 will be assisting doctor number 1, and the doctor 3 will be in charge of the IV line, secondary survey. If there is any chest drain, he has to do it, and he has to write the documentation also. The nurse 2 will be assisting the doctor 2. So all the roles are pre-assigned. It is always a multidisciplinary teamwork. Trauma is not, no single surgeon can claim that he is the trauma surgeon, because nobody is actually a trauma surgeon. Single person cannot handle all the traumas, because it is always a teamwork. There should be clear direction and communication between the team members. The pertinent findings should be verbalized in proper order. All team members should know all the findings of their patients. The work should be rapid and efficient, yet it should be calm and quiet. So this is the overview. First, you have to assess the airway. Look for the verbal response. If the patient is speaking, that means his airway is fine. If the airway is not patent, then you have to establish by doing the chin lift and head tilt or jaw thrust. Or you can then you have to look for, you can even put the laryngeal airway or surgical airway, that is the CRICOTHYROIDOTOMY. If his airway is stable, then you have to look for whether he is breathing or not. You can look for the pulse oximetry. If it is inadequate, you can go for supplemental oxygen. You can go for put a ET tube and go for assisted ventilation, and you can even consider tube thoracostomy. Sometimes the patient may be having tension pneumothorax. Suppose if breathing is adequate, then you have to look for the circulation. If the patient is in shock, then you have to start a large bore IV line, and you have to infuse at least 2 to 3 liters of crystalloid solution. Then you have to do, if there is external bleeding, you have to do just a pressure. Then if there are fractures, you have to splint that area. Of course, you have to do the chest x-ray, and you have to do the pelvic x-ray, and you must do the fast examination also. Suppose if the patient is perfusing well, then you have to do the neurological status by doing the AVPU. Then you have to expose the patient, you have to undress the patient, you have to see whether he is having any, especially over the back. If he is having any injury, that you have to assess. But the patient may go for hypothermia, so you have to cover him with warm blankets. And only after stabilizing the patient, after doing a thorough primary survey, and the patient is stabilized, then only you have to do the secondary survey. The secondary survey is nothing but your head to toe thorough examination. So the nowhere else you can see the significance of the teamwork. The trauma is always a teamwork. So joining together is beginning, staying together is progress, and working together is success. So in trauma patient, you have to work together to achieve success for your patients. So if you feel that these videos are very useful, kindly share with your friends. Kindly subscribe to get notified regarding my new uploads. Thank you very much for watching my video. Let us meet in yet another episode. Until then, bye bye.